Very good evening to all. We all know the incidence of cancers are rising in the past few years. And it's mainly because of cancers being diagnosed early. And there's also improvement in prevention and treatment strategies. So as general practitioners, we all come across patients who are taking treatment. And to diagnose and manage patients coming with the various oncological emergencies at the primary care level itself is needed before they can go to a tertiary center from where they're taking treatment, which may be very far away. And the traveling and all will be difficult. So today's topic, oncological emergencies and overview, is going to throw light on all these aspects. And this is being presented by Dr. Manuprasad, who is additional professor in Department of Clinical Hematology and Medical Oncology, Malabar Cancer Center, Thalassery. He did his MBBS from Government Medical College, Trivandrum, MD General Medicine from Government Medical College, Calicut, and he was a gold medalist there. DM Medical Oncology from Cancer Institute, Adayar, and he is actively involved in clinical research in oncology, and he has multiple publications in different index journals. He is also a principal investigator for multiple trials, and he's member of American Society of Medical Oncology, Indian Society of Medical and Pediatric Oncology, European Society of Medical Oncology. He's married to Dr. Adya and has a daughter, Mitra, who is in kindergarten. So over to Dr. Manuprasad for today's CM.
Good evening, all respected seniors and dear friends. At the outset, let me thank IMA Kannur for inviting me for this talk, and also to Lada Madam for the kind introduction. So I'll be talking about the oncological emergencies. I'll just give an overview about the oncological emergencies. As Madam has rightly pointed out, the incidence of cancer is increasing, and most of the patients who are coming to centers like ours actually go back to their places and then come back only for the next phase of treatment. So whenever there's an emergency, it's being taken care by the clinicians practicing the periphery. So it's very important to know about these details so that our patients will be benefited in a better way. So we know that the survival of cancers are increasing all over the world. This is the data from the US, where most of the cancers has shown significant improvement over the years. And the reasons for this improvement include early detection and advances in treatment. So advances in treatment include a lot of treatment directed the cancers, including a lot of exciting things are happening, including immunotherapy, precision medicine and all. And at the same time, another important factor is the improvement in supporting care, especially the hematological malignancies and such aggressive malignancies. The improvement in the supportive care also resulted in improvement in the outcomes of these cancers. So it is very important to manage these treatment-related complications to produce significant good favorable outcomes for our patients. So as you already mentioned, there's a very important role for the primary care physician, the peripheries, to achieve this goal, because the place where I was trained, that's Nadayar, it is located in Chennai. There all the patients used to come and stay in Chennai, and there are facilities where they can stay. So whenever there's a complication, they'll be coming to us only. So we were very confident of managing them. But in Kerala, the situation is entirely different. So people from faraway places come to us for chemotherapy, then they have the chemotherapy and go back. So whenever there's an emergency, most of the time they'll not be able to reach our center. They are being managed by our clinicians in the periphery. And this is not just matter of 1 week or 2 weeks. They'll be getting the treatment for a longer time. They'll be in and out of the hospitals, and they'll be coming from faraway places. And there are unique issues related to oncology which needs specific knowledge and management. And the most important thing is that if there's a delay, the prices are very heavy. We lose patients if they do not come to us in time, or if they are not managed well in the initial phases. So in this talk, there may not be anything new for many of the practitioners, but it can be a reminder for everyone so that our patients will be ultimately benefited. So the definition, so generally oncological emergency we define as any acute, possible, morbid or life-threatening events in patients with cancer, either because of the malignancy or because of the treatment. So these events may occur at any time during the malignancy. It can be during the diagnosis, and it can happen even at the end stage of the disease. So generally, we list out certain things under the category of oncological emergencies. These include superior vena cava syndrome, malignant spinal cord compression, raised intracranial tension, febrile neutropenia, and the metabolic complications like tumor lysis syndrome, hypercalcemia, and hyponatremia. So I'll be highlighting on certain important areas in this talk. So this is a common emergency that we see. It can happen at the time of diagnosis or even at a later stage. So this is a classical SVCO syndrome where the patient presents with facial puffiness, dyspnea, and engorged veins. And the causes can be non-malignant causes like thrombosis and then malignancies, most commonly lung cancer and lymphomas. So this can be life-threatening unless we manage it early. So most of the time the treatment is supportive measures, including proper position, oxygen support, and the role of diuretics is doubtful. In certain cases only it may be useful. The most important thing in this situation is an early diagnosis, because in malignancy related SPCO, what is going to change the outcome is treating the malignancy. So it most of the time it can be chemotherapy for tumors like lymphoma. Sometimes we use radiotherapy for tumors like lung cancer. And steroids, definitely in cancers like lymphoma, steroids can definitely reduce the symptoms. But we have to be careful in using steroids without a proper diagnosis, because many a time when there's an emergency, they get steroids. There can be a symptomatic improvement, but later when the patient comes to us and will do a biopsy, we'll not be able to make a proper diagnosis. So though that can cause transient improvement, the use of steroids should be with caution, especially in an undiagnosed case, because it can hamper the further diagnostic process. So another emergency that we come across is spinal cord compression. So we know it can happen in 5 to 10% of cancer patients, and common cancers resulting in spinal cord compression include breast, prostate, lung cancer, myeloma, and lymphoma. And the commonest site is thoracic. So any signs involving the thoracic cord, we should think of a malignant spinal cord compression. And in cancers like colon and prostate, even lumbar spine can be involved. And the earliest symptom is back pain. And on careful examination, we can elicit other signs of myelopathy, even at the earlier stage. So this compression can occur due to multiple reasons. It can be a vertebral lesion which can cause compression as in the initial image, or it can be an intradural or leptomeningeal deposit. And sometimes the transfer foramina involvement in disorders like lymphoma and neuroblastoma also can cause symptoms. And rarely we see intraspinal metastasis, so where patients come with features of intramedullary compression. So the most important thing in diagnosing this is high index of suspicion. So in a patient with cancer, especially advanced cancer, whoever comes with pain, low backache or back pain, we have to be very careful. It can be the early sign of spinal cord compression. Here, unless we intervene early, it can lead on to neurological issues. And once the patient is paraplegic or wheelchair bound, the entire cancer treatment will be compromised. So that can be the end of a proper treatment for any patient. So it's very important to identify this complication. And the earliest sign is back pain, and we have to be careful when the patients with advanced cancer comes with back pain. So there are other situations where the patients can come with back pain, like especially certain drugs like paclitaxel and the growth factors that give the vigilant diseases can cause back pain. But in advanced cases, back pain always rule out a spinal cord compression, and MRI spine is the most sensitive investigation. And X-rays, in this scenario, they lack sensitivity and they're grossly inadequate. So if there is suspicion, we need to get an MRI and start treatment accordingly. So the treatment is immediate thing that we can do is corticosteroids, which can relieve pain, it can reduce vasogenic edema and help in the neurological recovery. And there's been a lot of studies on whether to use high dose or low dose. High dose is like 96 milligram followed by 24 milligram per day. And low doses around 816 milligram per day. But there is no advantage for high dose. We can use even the lower doses of steroid. We should use dexamethasone. So, but when we use DEXA, especially in a cancer patient, we have to watch for complications like hyperglycemia, gastric ulcers, and also it can add on to the thrombotic tendency also. So the major treatment here is based on the cancer. So if it's a chemotherapy sensitive cancer, we can start chemotherapy at the earliest. So the certain cancers are not sensitive to chemo, they may require RT. In select cases, based on the status of the malignancy, there are scores to assess the spinal stability and the duration of paraparese neurological issues. Some patients, selected patients, will be going for surgical decompression. And in undiagnosed cases, the most important thing is urgent workup. And here also, as already mentioned, steroids are important, but we have to be careful before we administer steroids in undiagnosed cases, because it can hamper the diagnosis, especially in disorders like lymphoma and myeloma. And these patients have to be kept on DVT prophylaxis because malignancy itself is a high risk factor for thrombosis. And with paraparesis and weakness, the incidence of DVT is multifold. And they will be also start on other supportive and rehabilitative measures. So back pain, we have to be careful. Steroids are useful, but we need to be careful when there is the diagnosis is not established. So another complication that we come across is tumor lysis syndrome. This is an important metabolic complication. So it's mainly associated with hematological malignancies, but sometimes we see in certain solid tumors, there are certain aggressive solid tumors like choriocarcinoma and other germ cell tumors. There also we may see this metabolic complication. This is, as the term indicates, is due to the lysis of the tumor cells. So when the tumor cells are lyse, the potassium can come out, can result in hyperkalemia. They release the DNA, which will be converted to purines, and then in the pathway, as we all know, it can result in increase in uric acid. And also when the intracellular phosphorus comes out, there will be hyperphosphatemia, which can lead on to precipitation of calcium, resulting in hypocalcemia. And finally, they'll develop renal failure, and it can be life-threatening. Many of our patients with acute leukemia come in tumor lysis, and it's very difficult to salvage them. But most of the patients recover now because we have newer treatment options for these patients, and we are all on the lookout for any early signs of tumor lysis. So hyperuricemia is here, it's defined as uric acid more than 8 milligram per deciliter. Hyperphosphatemia is more than 4.5 to 5. Hyperkalemia more than 6, and hypocalcemia less than 7. So it's like a 5, 6, 7, 8 rule. 5 for phosphorus, 6 for potassium, and 7 for calcium, but that's hypocalcemia, and 8 for hyperuricemia. So and there are multiple definitions. We call it as a clinical tumor lysis syndrome, and the laboratory tumor lysis syndrome accompanied by an increase in creatinine level. They can have seizures, they can have arrhythmias, or sometimes it can lead on to death also. So these are the cancers which we commonly see these issues like acute leukemias, tumors like Burkitt's lymphoma, and other leukemias with very high blood counts. So those patients with very high blood counts, they are highly prone to develop this complication. So the treatment aspect is like prevention is the best option for this patient. So all the acute leukemia patients with high counts, they'll be kept on intense hydration. It's called as hyperhydration. So they'll be getting a hydration at the range of 3 liters per meter square over the 24-hour period. We have to be careful in patients with anemia and cardiac issues, but this is the most important step in preventing tumor lysis and related complications. And then we use this widely available cheap drug, allopurinol, which we can use up to 100 milligram per meter square up to 3 times a day. It is a xanthine oxidase inhibitor. We know how it works. So it will inhibit its enzyme and prevents accumulation of uric acid and related damage. So, and is allopurinol, when there is a renal failure, we may need some dose modification, but otherwise it's a safe drug. And in those patients, high counts and suspected TLS, early initiation of this drug can save lives. And now we have another drug called as rasburicase. It is actually a recombinant uric acid oxidate, because allopurinol will not be able to help in reducing the already formed urate levels. It just prevents further formation of uric acid. So rasburicase is a recombinant uric acid oxidase which can remove the already formed uric acid. So this we use in high-risk patients, and this is given as IV. The dose is 0.1 milligram per kilogram. Generally, we give a 1.5 mg dose because it used to be very expensive. Now that we have generics, the prices have come down. So, and also along with these measures, we have to manage hyperuricemia and hyperkalemia. And the calcium injections, we have to be cautious because unless there are some arrhythmias or ECG changes, we generally do not give calcium because it can further precipitate along with phosphorus and worsen the renal damage. So we have to monitor intake output clearly. Sometimes we seek support from the nephrologist, and dialysis may be required. So this is a major problem in a patient who is coming with suspected leukemia. And other things that we have to watch for in patients with suspected blood cancer include one is TLS, and another thing is bleeding manifestations. Some patients can have profuse bleeding initially itself, or also we'll have to actively look for the coagulation parameters, because there are cancers like acute promyelocytic leukemia, which can progress rapidly, leading on to DAC, and we may lose the patient even within the periods of 24 to 48 hours. So we have to actually carefully look for bleeding manifestation and the signs of coagulopathy and start correcting them. And some of the leukemias can present with mediastinal mass, and they can have SPCO, and it can also be life-threatening. And in patients with very high counts, this leukostasis and related complication, mainly in the lungs, they can present with desaturation and dyspnea. In the brain, they can present with neurological manifestation. So whenever there is a suspected leukemia, we should watch for these complications, start the preventive measures like hydration and other supportive measures at the earliest. So another metabolic complication that we generally see is hypercalcemia. So we know the commonest cause for hypercalcemia is hyperparathyroidism, where the patient usually comes as asymptomatic or sometimes with mild symptoms. But malignant hypercalcemia can come with multiple symptoms. So generally we see it in malignancies myeloma at the time of presentation, or lung cancer as part of paraneoplastic syndrome. But even other solid tumors, when there is extensive bone mets, they can present with hypercalcemia, as commonly we see it with breast, lung, and all. So they'll come with a CNS symptom. The patient may suddenly come with altered sensory in a comatose stage. And sometimes there can be renal failure, arrhythmias, polyuria, and GI disturbances. This can be life-threatening unless we treat it early. So mild hypercalcemia is less than 12 milligram per deciliter, usually asymptomatic. Moderate, also usually patients may not be that symptomatic, but when there is a rapid rise in the calcium levels, they can have the symptoms similar to the severe cases where the calcium levels go beyond 40 milligram per deciliter. So the treatment here also is most important treatment is hydration. So it also, we usually go up to 3 liter per meter square per day. Here also we have to be careful to prevent fluid overload. Sometimes we use furosemide along with this so that patient will not go into fluid overload. And in certain cases, malignancy, we generally do not use calcitonin, can help to reduce the calcium levels immediately. Otherwise, most commonly used drug for malignancy-related hypercalcemia is zoledronic acid. The problem is it will take 24 to 48 hours for this drug to act, but it can produce a sustained effect and bring down the calcium significantly. When there is renal failure, we need to modify the dose. Generally, we give it 4 milligram. So the creatinine levels is less than 60. It will be reduced in a stepwise manner, and less than 30 generally would not give. So another drug which is useful, newer drug is denosumab. It's a RANKL inhibitor. It can also be used in select situations. And steroids, they're not generally useful in all the cases, but in patients with myeloma or lymphoma, when there is hypercalcemia, it can help to bring down the calcium levels. So this is also another complication with which patients can present at different stages of malignancy. And some of the measures can actually be started from the periphery itself. And these are all complications mainly related to the disease. And there are also complications related to treatment. So we generally know the side effects of chemotherapy. Chemotherapy is just equal to side effects for most of our patients. So these are all well-known side effects. And vomiting is a common problem. It used to be a very major problem, but now with the better antiemetic agents, so the incidence of vomiting is definitely much lesser. I think everyone will agree with that. So we generally use drugs like dexamethasone, 5-HT antagonists like ondansetron, palnositron, and NK1 inhibitors like aprepitant. So and other drugs that we commonly use is lorazepam, and olanzapine is a very important drug for chemotherapy-induced nausea and vomiting. It is much cheaper compared to the other newer drugs, but very effective. So now we routinely start using this drug for patients with refractory vomiting. So this can create confusion because many patients have come back to us saying, like, in the medical shop or in the periphery, they told this is a psychiatric drug, why here the doctor prescribed it, but this is mainly used for the chemotherapy-induced nausea and vomiting. So we usually use it at a 5 mg dose from day 1 to day 4. These doses are well tolerated. The drowsiness is much lesser. So chemotherapy-induced nausea and vomiting, if it is severe also, we can use all these drugs. But generally, with all these drugs, it's well controlled. We rarely see patients coming with significant vomiting. But many of the patients will be having some sort of nausea, which we'll manage by adding on these drugs. And cytopenias is the most dreaded complication of chemotherapy. So it varies based on the drug. And the patient factors are also important because in a patient who is elderly, whose general conditions poor, they are more likely to develop cytopenia than a young and healthy patient. So this is an important complication. So as I've told before, like in Adair, where we used to study, patients used to stay there and they used to come to us for once in 3 days, 5 days to check the counts. But here, what we are doing is we are not routinely checking the count because it's adding on a lot to the patient. They have to come from the faraway places. So we just instruct them on the risk of complications, and they are advised to seek the help immediate clinician whenever there are signs which can be a consequence of cytopenia. So usually the cytopenia nadir occurs during the period of 7 to 14 days. It can be slightly earlier for drugs, docetaxel, it can be as early as 5 days. But otherwise, it's 7 to 14 days. So any patient who is coming after a week of chemotherapy with any complications, it's always better to check the blood counts because they can be having cytopenias. And as the neutrophils have the shortest half-life, they are the cell lines most commonly affected. And platelet are the next. And anemia also we see, especially in chemotherapy agents which are more myelotoxic. So, and it can be delayed in case of drugs like dacarbazine. And certain drugs will have a preferential effects on the cell lines because carboplatin mainly affects the platelets and cyclophosphamide actually platelet sparing. So now, because we are not calling the patients back, we liberally use this supportive measures, that is growth factors. So it is available in two forms. One is a conventional GCSF, which is available as 300 microgram vials. It is given subcutaneously. It needs daily dose. So those patients who are likely to develop cytopenia and those chemotherapy regimens where there is a risk of myelosuppression, that is more than 20%, we use these agents prophylactically. So we'll ask the patients to carry it, ask them to keep it in the fridge, not in the freezer, and have it from the nearby center. And also we can use PEG GCS. So that is more being used more commonly here. Because it's single dose. So we just give a single dose of pegylated GCS of 6 milligram, usually 24 hours after the chemotherapy. We should just space it after 1 day or third day of chemotherapy. So this can reduce the chances of neutropenia in a significant manner, but still some patients can end up in neutropenia. So this is the complication that is most dreaded in patients receiving chemotherapy, so febrile neutropenia. So this is very important because early intervention is the only way to improve the outcomes. So fever in neutropenic patients is defined as a single oral temperature of 101 degree Fahrenheit or a temperature of 100.4 sustained over a 1 hour period. And neutropenia is defined as an absolute neutrophil count less than 1000 per microliter, and severe neutropenia is less than 500. Also, any patient whose counts are likely to go beyond this level within the next 48 hours. So practically, any fever in a patient on chemotherapy, especially during the days of nadir counts, should be considered as FN, otherwise proven otherwise. Otherwise, it's shown that counts are normal. So who all are at the risk of febrile neutropenia? So there are agents which are having low risk, generally standard chemotherapy regimens for the most of the solid tumors. Here, the neutropenia, even if it occurs, it will resolve within a week. Then there are situations where it is 7 to 10 days, like for transplant patients, more intense chemotherapy for diseases like lymphoma, myeloma, and CLL, and high risk, especially that is after bone marrow transplantation, allogenic transplant, then acute leukemia injection consultation. These patients will be likely to be within the hospital or in the periphery or in the vicinity only. They're unlikely to go to the periphery, but all other patients will be actually going back to their own places, and they'll be seeking treatment when there is a complication. So the febrile neutropenia management is based on the risk stratification. So there are a group of patients who are low risk. So they'll be at the outpatient basis when the fever develops. There won't be any associated comorbid illness and anticipated shorter duration of severe neutropenia and good performance status. So performance status is the measure that we usually use in oncology to define the. It's a reflection of the general condition. So we call it as PS. So PS0 means it's a well patient, except that patient is having a diagnosis of cancer. He's like any other normal person. So PS1 is active, he's having cancer symptoms, but otherwise active and able to carry out all his activities. PS2 is like, they can do their activities with some difficulty, but may need some help in certain areas. PS3 is like, they need help for most of their activities. So PS2, PS3 are all either, they indicate a little more sicker patients. So those patients need urgent attention. And if there is no hepatic insufficiency and there is no renal insufficiency, they are considered as a low risk. And there's some risk index scoring to assess the risk. I'll come to it later. And high risk, they are those patients who have this index risk scoring as high. I'll describe it in the next slide. And they'll be inpatient at the time of development of fever. They have significant medical comorbidity and post-allogenic transplant. Those patients who are likely to have prolonged severe neutropenia, and those with other endocrine damage and other comorbid illness and with severe signs of infection. These are all high-risk patients, and they should be preferably managed in a tertiary care center. Other patients, there is a potential to manage them on OPD basis. So this is the risk stratification scores. So this is also just an objective measure of our clinical judgment. So it depends on the burden of illness, whether the symptoms are mild or moderate, and look at the comorbidities and also the status of the tumor and the treatment. So whether there is prolonged neutropenia or not. So all these are just objective measures to fine tune our clinical judgment. So those patients who are high risk, they should be immediately referred. Low risk, if we can ensure close monitoring, we can manage them as on outpatient basis. So OP patients, we generally give amox with levofloxacin. They need close monitoring, preferably daily follow-up. Any new onset symptoms, cultures positivity, and persistent fever, they are advised to report back to our center. And unless we are very sure patients will be listening to us, we won't send them, we will not manage them as outpatient, we admit them and treat as high risk only. So if all these criteria are satisfied, they are managed as OPD very well. If they can come to us regularly, we will be able to manage the complication well. And the high risk patients, they need hospitalization. We send the relevant investigation based on the history and clinical examination. And all the patients will definitely have a blood culture, 2 samples. If they have central line, sample will be taken from the central line also. So most important thing in preventing death due to febrile neutropenia is early initiation of empirical antibiotics. When there's a delay, the mortality can go up to 70%. So the periphery, if a patient comes with FN with high-risk features, we need to start the antibiotics early. Generally, the recommendation golden rule is that it should be started within 1 hour to achieve the most optimum outcomes. So which antibiotics we can use? Antibiotics, there are multiple options recommended. It is actually based on the patient factors and the local antibiogram. So we also generally change our antibiotic policy based on the antibiogram. So generally, we can use molecules like piperacillin, tazobactam, cefepime, sulbactam, and we generally use it in combination either with amikacin or levofloxacin. Now, other agents like cefepime, meropenem, imipenem, Macnax can also be used. So, Macnax is cefepime, sulbactam. There's a repetition. So our first line, as per our policy, cefepime, sulbactam plus levofloxacin. We have been using Piptas. Now the antibiogram is showing more sensitivity for cefepime, sulbactam. So that is what we are using. So in the periphery, if there is suspicion of FN, we can give 1 dose of antibiotic and then refer. So that will definitely alter the outcome of the patient. So next line, we use meropenem, imipenem. Third line is colistin or polymyxin. And now we use this newer antibiotics in refractory cases, which is ceftazidime, avibactam. And in sick patients, hemodynamic instability, there is no time to wait and see the response to the initial antibiotics. Directly, we have to go to the high-end antibiotics like Miro and ticoplanin. And based on the cultures, we can de-escalate. So we generally follow de-escalation policy because time is very precious in these patients. So early initiation of antibiotic is the most important thing. In certain patients, we use additional gram-positive coverage, like vancomycin, ticoplanin, linezolid, especially in those patients who had indwelling catheter, those patients with hemodynamic instability, skin and soft tissue infections, pneumonia, and also mucositis. I missed to include that. Mucositis is also an indication for adding gram-positive coverage like vancomycin and ticoplanin. And this here also we can stop if the cultures are negative. So we have to be aggressive if there are this indication, start these drugs. Otherwise, patient can lead on to further complications. And febrile neutropenia also, the most important thing is prevention. We advise the patients on hand hygiene, respiratory etiquette, food hygiene. So that is a little controversial. So we generally advise them to take mainly cooked food. Otherwise, there is no definite thing to advise as food hygiene. And fungal infections can be a problem, and there's a lot of construction demolitions. And we generally advise the patients to avoid visit to such places. And we use prophylactic GCSF whenever there is a risk of neutropenia. And in certain cases, like leukemia injections, prophylactic antifungals are used commonly so that the incidence of fungal infection has also come down significantly. Otherwise, previously, I mean, in centers, in countries like India, fungal infections have been a major problem, and loss of a significant mortality was being caused by fungal agents. Now there is prophylactic antifungals are being used in all these patients with high risk, so that fungal-related mortality is much lesser. So that is about febrile neutropenia. So it's a teamwork. So we need strict monitoring for fever, strict asepsis, meticulous supportive care, and the most important thing is early initiation of antibiotics. So I think here also it's prevention is better than cure always. And there are multiple complications related to the chemotherapy drugs. I won't go into all the details, but this particular combination I want to highlight because it is a diarrhea related to chemotherapy medications. Like commonly we use drugs like 5-FU, capstatin, irinotecan, mainly in GA cancers. So this capstatin, especially they'll be going home and taking it. Like it's like 14 days capstatin tablet, 1 week break, and every 3 weeks they come to us. So it can lead on to diarrhea, which can actually be life-threatening. Like the very few patients whom we lost during a treatment for a curative malignancy is due to this drug. These patients who develop diarrhea, unless we intervene early, it can be life-threatening and nothing can stop the diarrhea. And we very rarely we lost 1 or 2 patients just because of this complication. So any patients who are on capstatin, if they come with diarrhea, we have to be cautious. We need to ensure hydration electrolyte replacement. And in severe diarrhea, we need to stop the drug. And patients should be referred to the higher center. We can use loperamide here because it helps to reduce the volume. Generally, we suggest 2 tablets stat dose, then 1 tablet SOS. But maximum tablets should be 8 per day. And sometimes we use drugs like octreotide and antibiotics. But stopping the drug is important, and referral to a higher center is important because delay, we really lose the patients. So with this, I'll summarize. I'll just summarize like this. Early identification, management of complications, key in improving survival. We need a high index of suspicion for complications with febrile neutropenia, malignant spinal cord compression, and TLS. And teamwork is important with proper communication. And for FN, most important thing is early initiation of empirical antibiotics. So if there is any question.
Thank you, Dr. Manuprasad, with the excellent and very informative talk. The topic is open for discussion.
Excellent presentation. But one of the practical things what we face in the emergency department is probably classroom of patients coming with severe respiratory disease. So some of the centers are experimenting some other modalities like some universities, unless it is 16 as the next solution. Like, do you have any experience of controlling the resistance in a patient with probably plasma or severe lung cancer?
Sir, like, there are not guidelines on how to manage this patient. We also use all these methods, how to use the therapy. And the most important thing in reducing the symptoms to treat the cancer. The generally, either patient is not small, they respond immediately to chemotherapy. We need to start chemotherapy. That the cancer is very easy. So other methods can control symptoms or a part of it. I think the most important thing is to start the treatment. Instead, also our partners use the signal for symptom. But in this specific situation, I don't know if there's any definite not as a recommendation for this.
But if it's like any other active.
Yes, but like smaller cancer, they respond very quickly to the chemotherapy. So the earliest we start, they will become less.
Other problem in Kando or febrile neutropenia in children, say long definite centers with the now training ADA or the data. When we visit a pediatric oncology department, we assume that we are living in a place where there is no much facility. Do we have any facility in
we have a very good understanding of the oncology. So though I am very we have not seen they are separated children and all. So they have a medical needs. We have some medication especially focusing on pediatric, and they are also available nowadays. So I think it is completely changed. Oncology department we have a new law, and I think but
if doctors are not updated what is happening in other system, that may be a big problem.
Okay.
Like even pediatricians, that's not.
Okay, we have to, even the answer, I think I is taking our accreditation, streamline this other pathway also. So that is, farmers to our administration.
If they even pay here, we can have some other departments also, and it will be more familiar with.
That's very important. And many people not know all the things under the center. We need to not square. Yeah, GCS like you can use it properly. We use it based on principle of there are contrary evidence for the risk of smaller computers. So all those patients will have prophylactic GCS. That means everybody should think that you're talking. Yeah, so that's single look, that's I don't know the patient. But if it's transferred, we use the so you're so if the patient has a prescription that is wrong factor, is that non-way something from it, then generally safer to use it. So if you want to avoid the steroid of the we know that the costs are likely to in such cases, we can avoid. The other thing is good is if we it's better to use the loan factors. That is common. If you are using it, that's better.
Yes, water plants, basically.
On behalf of the Kannur IMA, I express our sincere thanks to Dr. Manuprasad for his excellent and informative talk on oncological emergencies. Thank you, Doctor. Also, thank all members of the Kannur IMA for attending today's meeting. Thank you.
In this law for